What's up, everybody? Zach Shelley here with Management Unfiltered, and we have
Kirk Teachout. And today we are going to talk about our top 9 KPIs and why they matter. Yes, 9 in the frame, right? So 9 KPIs that we focus on as office managers, that I focus on in my practice, as well as other practices that I work with, to really drive the practice to success, to keep overhead low, to see where we are as a practice. Are we healthy? Okay. So just a little bit of background. So this year, managing our practice, I have not even been in the practice except for 3 times, and 1 time was for a cleaning. So I was more or less the patient at that point. So in the only other 2 times that I went in was for training. It was for training to get the team back on board. Go through. We had some new team members, so it was about laying out the vision and how we go about it. But these KPIs are how I'm able to manage our practice from home and able to see, okay, are we meeting the standard, and really laying out the frameworks of success. And what does that look like? And as long as these KPIs are within these ranges, I'm good. And then I'm okay. But either way, we're going to go through this today. But first, Zach, let's talk about the first one. Okay. The first KPI that we're going to talk about is new patients. How many new patients do you believe is a healthy practice? And really, it's not even a practice, right? It's about new patients per provider. So how many new patients per provider do you think is healthy?
Oh, that's a good one, Kirk. There's a wide range of what's healthy opinion, right? Some doctors are like, man, I'm happy with 10, depending on the growth. But a good rule of thumb, in my opinion, for just a standard practice, if you work 5 days a week, 50 new patients a month, 4 days a week, 40 new patients a month, 3.5 days, 35 new patients a month, will give you a steady, solid flow of new patients, as long as what we get into in the later part of the attrition rate is not there, right? Which we'll talk about that in a few minutes. But, in our practice, our providers were running, 100 to 120 new patients a month. We saw almost 400, between reactivation and new patients, 486 was our highest month, with 4 of them accepting new patients. So depending on where these doctors are, 2 of our providers were still trying to grow their patient base, right? So the more new patients you're getting in month over month, the quicker you're going to get to that goal of, 1,000 active patients per day worked. So we do to try, personally, if we're growing a provider, try and bolster or double that average of, if you're working 5 days, you should be seeing, 100 to 125 new patients a month. If you're really trying in the first year or 2 to get your patient load where you want it to be, and then add on to another associate.
Yeah. So that's an important thing to focus on, right? It also depends on where you are in your practice, right? So are you looking to maintain, or are you looking to grow rapidly? Are you looking to add on providers? I know the last time, or one of the last episodes, we talked about, when to add a hygienist, right? So, we went over those numbers, and it's the same kind of with an associate. It's like, these are the numbers really that you need in order to make sure that you have the ability to add on an associate and it makes sense, right? Which we'll go over in a different episode, right? But I would say, yes, new patient flow for single doc practices that are working 4 days a week, 40 to 50 is healthy to me. So, the average new patient amount per month is around 20 to 25, but we don't like being average here, right? We like being above average.
So 26 new patients.
26 and above is above average, right? But that is okay. That is okay. If you're below that, let's talk, right? Because me and Zach both have ways that we can increase your new patient workflow. Mine is more of a grassroots workflow and boots on the ground to where you don't have to spend a ton of money. It's more sweat equity, and that's great. Zach has more of a marketing advertising approach, and that's great too. I've done both. But either way, we have the ability to show you how to do that. Maybe we could do another episode on just how can we get new patients, right? Which would be good. So yeah, let's add that to the list. But either way, new patients is important. But as we've talked about before, attrition or churn, or how many, in layman's terms, how many patients are you losing a month? That's equally as important, because you could have gotten those 26 new patients, but you had 30 patients that now are no longer active in your practice. So let's talk about that a little bit. What does it mean for a patient to not be active and that we lost?
Yeah, so if we're talking ADA standards, as a patient that hasn't been seen within the last 18 months, right, for an exam, hygiene, whatever you want to put it as, is they have not been seen in the last 18 months of the practice. So we consider those, patients that are walking out your back door, which are typically the patients that aren't reappointed, which we'll talk in a minute. But those patients that are not coming back to your practice because you didn't follow through with them. They found another practice, you didn't deactivate them. And the biggest way, I love having the conversation. People are like, oh man, I had 150 new patients this month. I'm like, that's great. What's your attrition rate? And some people will snap back and say, we only lost 20. I'm like, that's awesome. Okay, so you had a growth of, 130 patients. Some people are like, wait, what's that? And I'm like, okay, well, if you're talking about growth, where's your loss? Because you need to know how much your practice has actually grown. Oh, well, that doesn't matter. Well, actually it does, because a lot of practices are silently dying behind the scenes because they're not looking at their paycheck. And when I say they're not looking at their paycheck, it's the new patient paycheck, because your net growth is after taxes, and your tax is those loss of patients every month, your attrition rate, your churn, whatever you want to talk to. So we're looking at a new patient paycheck, right? And that's where a lot of these practices were growing. Like Kirk said, we got 26 new patients, but we lost 30. You have a net loss of 4. So you're actually decreasing in your active patient load. And a lot of dentists that, you're running docs, these offices, and you're like, I want to see more and more and more and more, but you're not understanding where a loss is. One of these places I would look is your attrition rate and say, hey, am I actually growing? And if you're not, let's understand why, because there's a lot of different things that you can do, and you can do a root cause analysis and say, okay, these are all my procedures. Where are these patients falling through the cracks? And when we start finding out where our patients are falling through the cracks is when we start unlocking the ability to grow our practice in an effective and efficient way.
And that's where one of my favorite metrics to look at in this new patient metric, KPI, is the recapture rate, right? So it's about seeing new patients. That's cool. Those are people who have never been into your practice, minus the patients you have now lost. But the cool thing is that you can see how many you recaptured from that pool of inactive patients. So even if you had 26 new patients come in that have never been in your office, you lost 30, that's a net of -4, right? But let's say you recaptured 15. Now you have grown by 11 patients that month, which is great, because let's be honest, if we haven't seen that patient in the last 18 months, there's probably quite a bit of work that needs to be done. So, between hygiene, between active bacteria in somebody's mouth in 18 months, there's a lot that can be recaptured inside of that patient, right? Not from even in a numbers perspective of just getting the patient 100% healthy, right? So it's just as if they're a new patient, which is why I look at that recapture rate of, okay, we have new patients, we have lost patients, we have recaptured. So as long as we can get a positive net, obviously trying to get that up, we want to have a positive net of 26 or above, right? Per provider. Now, once again, if we can get to that 40 or 50, that's awesome. Sometimes that's even more, depending on what stage you're at. But that's what new patient KPIs, and just for KPIs, I know we didn't say this at the beginning, key performance indicators. Okay? These are numbers that we look at all the time to make sure we can determine the health of the practice. So new patient KPIs, new, lost, and recaptured. Reappointment rate is number 2.
With the recapture, we talked about earlier with attracting new patients, which this will fall into the next episode. But if you do take a marketing standpoint of, boots to the ground, or the dollar for dollar of added Google and Meta, you need to understand when you're recapturing, you've already spent ad spend on these patients to attract them to the practice. So they're more likely and easier to recapture if you're intentional about the process of doing it, because they've already had a hopefully good experience with your practice. So those are good ways to get your net patient load up and push against your net negative. So just a thought process for you guys to have is those recaptures are really important, but they're also an easy one to attack and approach because they've already experienced your practice.
Yes. Okay. So number two is reappointment rate. So this is again a backdoor issue. So if you have people coming in for hygiene, like let's say they're marketing patients, they're advertising patients that are coming in, or they're just your normal average active patients, your established patient base. If they don't get reappointed or rescheduled for their next cleaning, then you have a problem. You have a backdoor problem, because they're not going to come back in 6 months unless they think about it. And most of the time, I'm super busy. I don't think about it.
They're going to call back when they check their schedule, Kirk.
Exactly, which is never. So we are very low, on the totem pole as far as priorities for most people. So we need to get them back on the schedule. And one of the ways that I look at this is I'm okay with having a 90% reappointment rate. That doesn't mean it has to be 100% because of, whatever. Oh, we want to have everybody. Like, no, I don't necessarily want everybody to come back. Right? So we heavily focus on our ideal patient, people who accept our treatment plans, who are okay with x-rays, who, don't refuse things just simply because they have a different mindset than what we have in our practice. We have a standard in our practice, and we hold everybody to that. So I'm okay with a 90% reappointment rate. So let's just say 8 patients come in on the hour. We have one that doesn't, reschedule. That's okay. Totally fine. And for some, there's circumstances, sure. And there's ways to overcome that. And I think another great episode that we need to add in is objection handling. I think that would be an awesome episode because this is where objections typically come in, right? When you're getting them on the schedule 6 months from now. I don't know what my schedule looks like 6 months from now.
I object.
Right. So the objections are real and they're valid, right? But there are ways to get around that. So, Zach, let me stop talking a little bit and let you talk a little bit. So what do you typically look at to try to drive this 90% reappointment rate?
Yeah, so first off, you have to look at it, right? There's a lot of these metrics we talk about, and a lot of times offices don't even know what the reappointment rate is or even know what a KPI is, unfortunately. And docs, if you haven't done that, don't be embarrassed, but start now. Start tracking these. If you don't have a software to do it, there are great softwares out there to do it, but there are some that you can do manually until you figure out what you're wanting to do in order for you to see exactly what's going on in your practice. But what's managed is measured, right? And what you don't manage isn't measured. And getting somebody to look at these and say, okay, we're going to decide, 90% is our threshold. So how do we communicate? And handoffs play a big role in verbal communication between teams, but also in front of the patient for them to understand the necessity and the importance of coming back for their next cleanings and next appointments. So a lot of times our team would bring the patient back and we're saying, hey, we got Kirk here. He's, got no additional treatment needed, but we need to get him scheduled for his hygiene. The hygienist is going to do it in the back. If they don't see it up front, then the front office team's going to say, hey, I'm going to go ahead and schedule your next appointment for you. And they're like, oh, I don't know what my schedule looks. Not a problem. Let me go ahead and just pin this date for you. And then I'll call you back tomorrow so you have time to look at your schedule just to confirm that date's perfect. If not, we'll move it out a couple more days. And we're making sure that we're holding our patients accountable, because 99% of the time we get them on the books, and these are patients that we want to come back. The ones that are like, not our ideal patient, we may let that be an easy, push off to the side. But the other ones that book, they're not going to refute that. And if they are, they usually call back pretty quick. And then they show up for those appointments because they know how important it is for them to be able to get in. And you also show them that importance of listen, if I don't get you scheduled, we're actually going to be pushing you out 9, 10, 12 months. I want to make sure that we have the time for you. And you have those intentional conversations saying, hey, it's important to me that you show up for your next cleaning because I want to make sure that we don't get anything to start brewing in your mouth or, if they need SRPs. The biggest thing is being very intentional, like with our SRP schedule. If you need 2 hours, like I have my hygiene team looking like, hey, I've got them coming in for these 2 quads. I notice this patient can slide over to this hygienist, gives me 2 hours in the next 2 weeks. I'm going to go ahead and move them remove that next appointment and get them pushed in there so we can get it done in a timely manner. So it takes the entire team to strategically look at the schedule and understand how important it is to get these patients on. And then also a follow-up system on the patients that didn't schedule. Are you calling them back the next day saying, hey, Mr. John, you said I'm going to call you back and look at my schedule. I didn't hear from you. I really want to make sure we get you on the schedule. Does this date work? Have a date picked out. I notice that you frequently come on Mondays. Mondays look like a good day for you. And 9 a.m. has been the time that you've always booked. I've got a Monday at this time. And you start preaching it right back to them. And they're like, oh, dang, they know me better than I know me. Yeah, that'll be perfect. But you give them options rather than saying, what would you like? Heck, there's a lot of that I would like. I would like to not go to the dentist, right? So let's offer them times and slots that work best for them because we care and we actually recognize what their schedule habits are.
Yeah, and let's assume that they're going to schedule. I think that's a big piece that we miss in most kind of verbiage and different things. Like we ask, would you like to? Like, no, let's assume they want to schedule and say, hey, I have these 2 options. Like you're saying, like give them options. And if it doesn't work, then find other options. And that's totally fine. Like the goal is to keep them on the schedule at all times. So then we move into also what's the best time. To me, a great time, hygienists, is when you're waiting on the doctor. To me, it's when you're waiting on the doctor for the exam. Like you went and got the doctor. They're not coming immediately for the most part. So go ahead and like, hey, while we're waiting for Dr. John to come back, hey, let's go ahead and get you scheduled for your next appointment. It's a Monday afternoon. Are those best for you? Great, cool. I have this date at this time. Does that work for you? Okay, great, cool. Done. That fills the time that you're waiting on the provider.
And you get this rebuttal too of like, well, I don't know what's going on in 6 months, and say, but we do. So we can save a time for you in 6 months. We know what's going on in 6 months. So we do, and I'm going to hold this for you so you can book around this. Morning or afternoon best, and you start asking and you drive those questions. And like you said, the doctor never comes on time. Doctors, the day you start coming on time, the hygienists aren't going to know what to do with themselves. So we're going to utilize that time that your hygienist is working to get treatment scheduled, to get their next appointment scheduled, talk about, their dogs, their cats, their cruises, and forming that relationship. But getting that appointment schedule is key. Get your hygienist to book this while they're waiting on you.
For sure. So number 2 is the reappointment rate. So 90%, that's the goal, right? 90%. The next one, number 3 is treatment acceptance rate. Ooh, this is a hot topic, especially for doctors. Their treatment acceptance rate. What is your thought process, or not thought processes? What do you look for when you're looking through treatment acceptance percentage? And what does that mean?
The percentage of treatment that is accepted by the patient, right? It's not a very hard metric to follow.
I can accept treatment, but what does that mean?
So if you have 30 things on the schedule or on their treatment plan, if you accept one of those, that is treatment acceptance. The way Dental Intel tracks it, the way that all tracks it. So if that's, if you do one of the 30, that is 100% treatment acceptance because they accepted some sort of treatment that you provided to them. But there's going into another metric that we'll talk to in a minute, which is the dollar percentage, which is really what gets deeper with this. But what that looks like is if you don't have treatment acceptance, period, you got to really rethink how this is being presented to these patients. Quite honestly, because patients are not accepting because they don't understand the treatment that you're presenting to them. Now, when it goes to the dollar, it can go even deeper into that. But you really have to look at, like, if you have 50% treatment acceptance, that means half of your patients are accepting treatment. Okay? Which, half of them are. We can argue one way or another. Half is better than none. Yeah. But what about 8 out of 10 of your patients accepting treatment? Right? Like, let's start talking 9 out of 10, 10 out of 10. Like, what does that look like? Because when you start looking at that, that's when you start seeing these big growth factors and metrics in your practice. And it's not just when that treatment acceptance increases, patients collections increase, insurance collections increase, patient referrals increase. Like, there's so many things that drive underneath it, but you really have to look at the beginning. Are you confusing your patients? Are you spending the time for them to understand? How are you handing things back off to the hygienist saying, I will see you back for that crown? And then the hygienist takes, what day and time works best for you? Let's go ahead and, oh, well, I had another question about that. Yeah, let me answer that for you. Empower your hygienist, empower your assistants to help educate these patients on why they need the treatment and what the doctor explains so he can move on and continue. And you can continue to educate them, get them to understand, because guess what? They're going to trust the hygienist way more than they are the doctor when they're having these conversations about treatment and closing that treatment and moving forward.
That's super important to realize is that I know that especially coming out right out of school, a lot of new grads, and my wife was the same, feels like the treatment acceptance is all on their shoulders. And it doesn't need to be. About 80% of it needs to come from the team. So that way everybody's working at the height of their license. So like you were saying, like I call it the circle of success, right? So you come in, you have the hygienist warm up the patient. They see the things that they see, right? They're a licensed provider. They know what they're looking at. And if they don't, then the doctor, you need to educate your team on what you typically see. And this is what you typically would diagnose. So that way the hygienist and the assistants can be like, hey, there's a crack on number 5 on, you don't tell the patient this, but there's a crack on number 15. So there's a crack right here in the upper left that we need to address. I think Dr. John is probably going to say that needs to be a crown, but I'll confirm with him and he'll come in and make sure that that is what it is, right? So do you have any questions on what a crown is, on what that process is? No, you wait, Zach. You wait. For those who are just listening, he's raising his hand. That is unacceptable right now. So I'm walking through this process. But, it's just like, do you know what it looks like to have a crown? We do them in-house here. We mill them, so you don't have to, have multiple appointments and multiple temporaries and things because they always break while you're on the weekends or while you're out on the weekends. And they walk the patient through what a crown looks like or what an implant looks like. So that way they're educated. So when the doctor comes in, they've lobbed this up to where the doctor can now walk, like just knock it out of the park of, I agree, this is a crown. You need to get this done quickly. And you have that sense of urgency. And you could just kind of go from there. Now, Zach, what did you have to comment on that?
So there's a ladder in docs that you're listening to this. Train your hygienist to take IOPs along with your x-rays on all of those cracked teeth. And I'm going to explain why. I was just talking to a doctor today that said, hey, we're having trouble with claims because the insurance isn't paying it. We had a massive crack in the tooth, but we did not take an IOP. There's 2 factors with that. One, insurance is going to cover that because they're going to see it. But also, the patient's going to accept treatment once they see that picture. And they say, you see that big line right there? That's a crack in your tooth. And if we don't do anything about it, this is what it could turn into. And you can have a picture of a very ugly tooth right next to it that is nasty and bleeding and painful, and understanding you're hitting those aspects of get your hygienist to work on the opposite end of just not just teeing them up, but also the documentation. So when you get in, say, my hygienist actually took a picture. Let me show you what I'm seeing. The biggest thing I always hear, even from my own family, the doctor said I needed a crown, and all I feel like is he's just trying to sell me more treatment. I was like, well, did he explain to you why you needed it? Well, he said something about this, but it didn't really explain it very well, and I didn't understand, so I'm not doing it.
Yeah. It's a lack of education.
It is. And then they end up with a toothache because they needed it. The doctor wasn't wrong. They just sucked at presenting it. And the team did not slam dunk it. They airballed that all day long.
So you have to really, which like I said, we can go deeper in this in another episode on treatment acceptance, but you have to really empower your team and get them up to speed. So that way, it's just a better patient experience in general. Right. Another thing that I do is and just for information, IOP is intraoral photo. Okay. So for anybody who doesn't know that, intraoral photo.
Photograph.
No, it's photo. So if you have a TV in your op, okay, throw that sucker, throw the IOP, the worst IOP that you have on a tooth, and you throw it up on the screen while you go get the doctor hygienist. Let that patient sit in it and see what is on the screen. they will 9 times out of 10 say, I don't want that in my mouth anymore. Right? I don't want it to look like that anymore. So it's very simple to close.
Yes. And now I'm going to take the reins and I'm going to turn this right back at you, Kirk.
Oh, before you go into that, what is the acceptable treatment acceptance percentage?
I'm going to throw that right at you. What is your acceptable treatment percentage?
Okay, acceptable is at least 50%.
Yes, I would agree with that. What's the ideal? So go with the average and then give me the ideal,
Okay, so the average across the US is 33 to 40%.
which is garbage.
Yes, that means that less than half of your patients are accepting treatment that you're presenting. That's like everything. If they accept, like Zach said, if they accept one filling that you presented out of 10, that's 100% treatment acceptance. Less than half of your patients are accepting some sort of treatment that you give them. That's terrible. The acceptable is 50%, but all of my clients and my wife is at 80% plus. So that is the bar. That's where we want to get 80%. So 8 out of the 10 patients that you saw that day that you presented treatment to get something scheduled. That means accepted. So scheduled means accepted. Okay. Now, moving on to the next one,
Which is
treatment dollar acceptance. Okay. So it's one thing to have one filling that is now accepted or scheduled. It's another thing to have multiple fillings, so quadrant dentistry, accepted. So the average across the board, again, is about 20 to 30%. So they'll have about 20 to 30%. So 2 or 3 fillings out of the 10 that you presented are going to be scheduled.
And just real quick, so you know where Kirk's going, guys. Out of $1,000, that 20% is $200.
Yeah.
Just so you guys are tracking what he's saying.
Yes. The goal for all of my clients is 50%, meaning $500 out of 1,000. Okay. So 5 out of the 10 fillings are now scheduled, meaning like we have a quad of dentistry that needs to be done. We do it and we get it scheduled. Okay. Because we're promoting quadrant dentistry, not one tooth dentistry. Because you're already there, you're already numb, might as well get it done. Right. Now, this is a fun metric for me because this is what I drive. And this is where my wife is really great. And it's not just my wife, it's also, once again, it's the team. So they are driving this number, and then my wife is knocking it out of the park and it's getting scheduled. Now, we have this metric. My wife presented $100,000 of treatment. 87,000 of it got scheduled. That's an 87% treatment dollar acceptance, which is very elite, I know. And that does not happen every single month. But the goal is to get to 80. For us, that is our goal. Now, if we're looking at treatment acceptance and treatment dollar acceptance, my metrics that I look for at least are 80% treatment acceptance, meaning 8 out of 10 of the patients schedule something, and then 50% in the dollars. So making sure they at least scheduled 5 out of the 10 fillings that we presented.
Yeah.
Make sense?
To me, it does. Hopefully, it makes sense to everybody else.
And if you have questions on these, please comment, leave a 5-star review and comment. And if you're like, hey, I need more access to this, like I need more knowledge on this, great. Hit me up on Instagram at Kirk Teachout. Make sure you hit Zach's group as well. Domlin.
Dental Office Management Leadership Network, DOMLN.
But that's number 4 is the treatment dollar acceptance percentage. I think that we've hit it. I don't want to beat a dead horse. So let's move on to 5, okay, which is the collection percentage. What is an acceptable collection percentage, Zach?
I think 98% or above. I think if you're under 98%, you're missing, and you're just missing the mark. There's things falling through the cracks, and 97 ends up 96, then 95, then 94, 98% or above. And you have some factors that play that, oh, well, this office is doing over 100%. Well, yeah, sometimes you're fighting insurance on, secondary claims that have taken, 90 plus days to pay on. So some months you might have 110, 120, or you have past due AR you've been working on for a long time. It's finally flooding in. Like, it's not necessarily a bad thing to be over 100%, because you want to make sure you're getting all those dollars in your doc's account. And doc, you want to see that collection percentage stay consistent. If it's slowly, consistently going above 100% and holding, that's good, because that means you're getting all that past due revenue coming into the practice, which you want to make sure that you collect and not just write off. So there's a lot that is missed when it comes to collection percentage, because they're like, oh, we're 95%. And I'm like, I had people apply to the practice before that said, proudly, kept our collections at 90% for 5 years. And I was like, dude, you've been losing 10%. Like, I'm not even going to consider you. You're way under the mark of what I would want. Like, no, thank you. So you need to make sure that you're staying at 98% or above. And if you're not there, start figuring out where your cracks are falling through. Are you just writing insurance claims off? Are you just not collecting from the patients? What are your systems that you have in place to make sure that your dollars are coming into the practice and actually making it to your bank account? Because production means nothing if you're not able to collect on it.
Right. So like getting better estimates for the patients, right? If we're seeing a lot of downgrades and things like that, we need to make notes of that, right? And make sure that we're telling the patients that and collecting that on the day of. I remember when we bought the practice, the patients were so used to just walking out the door as soon as they had something done. It was like, okay, well, just bill me after insurance gets back. I'm like, no. So that was honestly the biggest shift for our practice at the very beginning. But it makes a lot of sense. And like that's like you were saying, consistently above 100%. So ours typically ranges around 105 to 115% of collections. Now, the reason for that is because we take deposits for doctor time. Because and we go in and out of this ever so often, but for the most part, it stays pretty steady if we take deposits, and it's just a $50 deposit that goes towards the treatment. And they lose that if they don't give us 48 business hour notice. And they know that. But it's because our doctor's time is very valuable. And we go above and beyond to respect the patient's time and making sure they're not waiting a ton of time. So we also want the patient to respect our time. And most of the time, a lot of people are like, oh man, you do deposits? Like my patients would never enjoy that. Well, the patients that won't pay that and won't enjoy that are the ones that won't show up anyway. So the ones that pay that happily and they understand it goes towards their part anyway, it doesn't matter. So the reason why we stay there is not only doctor time, so $50 for the doctor time. If it's larger cases, we do 25% down to get on the schedule. But then if it's SRP, we also take a $100 deposit because we also block 2 hours for that, right? So, or an hour and a half, depending on the patient. So we do take a $100 deposit for that. But beyond that, that's good. Like 98% to and above is good. That's where you want to really set with that KPI. So collection percentage, number 5, collection percentage, 98% or above. Number 6, AR days. This is a good one. How long does it take, or how outstanding are your patient balances? How long does it take for you to get paid once you have insurance claims? So what is the standard metric for you, Zach?
The standard metric typically is 45 days or less. You and I feel like, are on the same kind of page around 25 days. Because we want to make sure that we are doing it effectively and efficiently. Because if you really think, like 45 days, that's a month and a half on average that it takes for you to collect a patient balance, which is too long, in my opinion. I think it's way too long, and we can do it way more efficiently. So around 3 weeks, just over 3 weeks, is a fair value that I think gives us enough time to get all the documentation to the patient or to the insurance company to make sure we're collecting efficiently and effectively.
Yeah, I think ours is sitting at like 30 days right now, 28, 30 days. And that made me actually this morning, I was looking through and I was like, oh, okay, well, I need to look at my 90 days past due, right? And my 60 days past due, because like that's moving that number further. But the average is 45 days, right? But once again, we're not standard, we're not average. So we're going to try to get that as close to 25 days as possible. 20 to 25 is great.
So 44 is above average.
Yeah, so 44 is above average. Let's just point that out. But yeah, so that's a simple one to look at, simple one to really make sure that you get collections better in general, just getting better estimates and making sure statements go out on a monthly basis and different things to collect, right? So that's number 6 is AR days. Number 7, I'm going to go into the P&L over the next 3. Okay, because these are the things that I look at every single month, every week, all sorts of things. So number 7, supply costs. This is outrageous for most doctors, right? What is the average supply cost? Do you know, Zach?
I actually don't know the average, but I know a lot are 15%. around that marker, which is super high.
10 to 15 is average, but what are our targets for this?
Ours is in between 3.5% and 4%.
Yes. And a lot of doctors are like, how in the world are you doing that? Well, one, we're not allowing somebody to just order whatever they want. And we're also setting a budget, right? So I don't know how you guys do it, but typically what I do for people is I tell them to look at the average collections over the last 3 months, and whatever that average is, that's our budget. 4% of that average is our budget for this month to stay under. And honestly, it's fun to try to stay under that budget for a lot of people. And sometimes, like if you really can't drive it, then sometimes like we'll do a $50 bonus if you can stay under budget, right? For whoever's in charge of that. Another way that we, keep under this budget is by our assistants and our hygienists and stuff will fill the carts, but then we have somebody else that goes through and approves it, right? They're not just ordering it just to order it, right? So we have that, and at the end of the week or at the end of the 2 weeks, whenever you order supplies, that's when we do that, just for approval. But I don't know, what are some other ways that you have been able to get that 3.5 to 4%?
Buying groups are helpful. Always looking out for deals. When we buy our composite, we buy 10 to 12 boxes at a time so that it can be utilized over, a shorter stint to where they don't go expired, but you bulk it together to get, per unit cheaper. But we also, budget is the biggest thing. You look at it and say, hey, we have this, not allowing your team say, I want this. We consolidate materials. So we're using the same thing across the whole office. So one doctor's not using Omnichroma, the other one's using a Mirror Fusion. They're all using different bonds. That's where you end up with a ton of wasted materials. Training your team how to use your materials correctly. With Scotch-Bound Universal, you need a dot of this stuff. It's like $240 for a bottle, and if I recall correctly, it's over $50,000 a gallon. It's very, very expensive, and teams don't understand this or throwing instruments away. So there's different strategies to do it, but making it known to the team, you're not going to order whatever you want, and you have to follow what we're doing and telling people no.
For sure. So we have supply costs. We also have, that's number 7, supply costs. Trying to keep it with 3 to 4. Another tip with this is don't fall into the trap of buy 5, get 5 free. Sometimes that's just not what you need, and that is okay. If it's not within your budget, don't use it. Now, if some people are like, oh, well, but this month I have this yearly, cool. Well, let's look at the average of the year. Are we under 4%? You can add back in if you need to, but try to stay within that 3 to 4%. So that's number 7 is supply cost percentage. Now, 8 is lab costs percentage. So lab costs, ours is 1 to 3% in our practice. Now we do mill in-house, but we even saved $40,000 this year by switching our lab. Zach, what are your typical lab cost percentages?
In between, so on average, you should be under 10% between lab fees and supplies. We're about 8%. So our lab fees are around 4%. And a lot of ours, what it is also linking up doctors using the same lab, so you get volume discounts. And that's the biggest thing, is getting DSO pricing, like you were saying earlier, saving up to 40% by doing that, being part of a buying group, figuring out ways to bulk things together. So volume discounts are going to be your biggest thing, or milling in-house if you have the machinery, and understanding that. But that's the best way we've done it, is we get all of our providers on the same page. These are the labs that we're using. These are the approved labs. Because shipping costs, model costs, all those things add up to a ton of money if you're not watching it.
For sure. And if you do want that DSO pricing, make sure to reach out to me, because I can give it to you right now. So it's very simple. And the lab that we switched to is incredible. Not only digital focus, but also they really focus on the quality, which is great. A lot of people feel like the cost to quality ratio has to be there. Like, oh, high cost and then high quality. Like, no, it doesn't have to be. So you can get your lab cost and your supply costs under 10%, right? It's not impossible. And imagine adding an extra $100,000 to your bottom line because you have these two metrics in line now. These are super important to watch. Okay. Now, number 9. This is the last one, but to me is the hardest one to really dial in, and that is payroll percentage. Payroll percentage. I'm going to let you start with this because I'm going to go over mine and people are going to throw up. So let's go over yours first. What is your acceptable payroll percentage?
25%.
25 to 30% is the average across the US for everybody who needs to know.
Biggest way I've noticed practice is losing out on money and losing out on payroll. And they're always like overtime, overtime, overtime. Do all of your employees work full time? Because I'll tell you, your biggest portion of where you find paying way more on payroll is the people that don't work full time, that are under the radar because they're not getting overtime, but say they're scheduled for 20 hours, but they actually work 30 hours every week. And you're not even recognizing that because you're not tracking and tracing it. So that's one thing where the practice is so big. We have 38 team members. If we can keep it at 25%, we're super happy. Super happy. And that's where we typically keep it at. But there are different factors that you end up falling out of that because you're not tracking and tracing those right things.
Just for everybody to know, like payroll percentage is not including the doctors. So this is including everybody except the doctors. Okay. And I don't include outsourced, as payroll. Like anything that's outsourced is not payroll either. That's an expense to the office. So I am looking at your hygienists, I'm looking at your assistants, your insurance team, whatever, like if they're in-house, and your front. These are the people who fall under this payroll percentage because these are your fixed costs. Doctors pay for themselves, or should anyway, if they're at a percentage. And sometimes you put the office manager in there, sometimes you don't. It depends on who you have and what you're doing, right? But I like to keep it at least 20%. That's my target for every single office I work with. 20%. And our office is at 17 to 18% at all times. So we run mean and lean. And a lot of that has to do with the systems we have in place to make sure we're working at the height of our license and we're producing more that way. And that's cool. But most people can't get to that, and that is okay. But the goal is to try to get to 20%. And to your point, you can track overtime hours. That's cool. Another thing is that I see people that are they're overstaffed. Right? They'll have 3 people in the front. I had this one doctor we talked about already that had 5 people in the front for one doctor. I'm like, that is a problem. So for how many doctors, how many people did you have in the front?
So on the one side, we had 3 for 3 doctors. On the other side, we had 2 for 2 doctors.
That's a typical standard of what you can do there. Another, honestly, we've gone over this already with the front, is about 1 million to 1.5 million per person in the front. That's kind of like the gauge to me, because I was doing it by myself with 2 doctors for over that. So it just depends on kind of who you have and what's going on. But still, that's the goal. The goal is to get to 20% for me, 25% depending on the size, like Zach's talking about. But those are your KPIs. So just a real quick recap. We've got the 9. 1 is new patients. You need to track your new, your lost, and your recaptured.
I'm counting on.
Oh, okay. Number 1. Okay, cool. So number 2, reappointment rate, 90% or above. Okay. Number 3, treatment acceptance rate. It needs to be 80%. 8 out of those 10 8 out of the 10 patients need to have something scheduled. Number 4 is treatment dollar acceptance rate, which needs to be 50%. So 5 out of the 10 fillings that you presented need to be scheduled. Okay. Number 5, sorry, that was number 4. Sorry. So number 5 was collection percentage. Collection percentage needs to be 98% or above. 6 is AR days under 45. Under 45 days that you're collecting. 7 is supply cost percentage, which needs to be 4% or below. 8 is lab cost percentage, which needs to be 4% or below. And together, at least 10% or below. And then number 9 is payroll percentage, 20 to 25%. That is elite metrics, guys. KPIs, these are the ones that we look at all the time. Zach, what else do you have to say?
Hit the YouTubes, Like, subscribe, share the episode. Start commenting, guys. We want to talk on what you want to learn about. We're not going to shy away from the hard subjects. We're not going to, go away from, oh, that's going to be too hard to talk about, and we're not going to do that. That's not what we do. We want to hit the hard subjects. We want to do everything to make your practice better, clearer, and more effective. But start tracking these metrics. Let us know how it's going and how we can help.
Yeah, for sure. For sure. Guys, it's been another great episode of Management Unfiltered. I'm Kirk Teachout. That's Zach Shelley. And we look forward to hearing you on the next episode.
We'll see you soon.
Come on, give me some.